up at the beginning, we've been having some amazing problems with audio. We think we've got everything fixed, but if we start losing audio, just stick with us, and we'll have it back as soon as we possibly can. I want to take a second just to invite you to our next webinar. It's December 19th with Brad, and I don't know how to say his last name, so I won't try it, from the University of Utah. He's going to talk about the house call being back and how it's better than ever. We'll send out an announcement on this and let you know a couple different ways that we're having it, just to remind you to come back. But let me quickly run through our Adobe Connect room here and kind of give you a sense for what we're looking at and what we're doing today. The top module on the right is the attendees and presenters module. You can kind of see who's there and who your friends are, I guess. The file module just below that is an important one. We'd invite you to download our Northwest Regional Telehealth Resource Center 2014 conference card. That tells you when and where the conference is going to be, and you're certainly welcome and encouraged to join us there. The module below that is a web links module, and on there you can click on any of those titles. The SurveyMonkey will let you give us some feedback on today's webinar, and we'll also give you an opportunity to tell us what you'd like to see in the future for webinars. And just in case you're the kind of person who doesn't like to click on links to go to surveys, Martha will put the survey website up on your screen as we finish up today. There's also more information on the Telemedicine conference coming up in March, recordings from the past webinars, and tell all your friends and neighbors that this webinar will be recorded and be available on our website within a few days so that you can re-watch it. You can also sign up for our newsletter. We have a bi-monthly newsletter that's full of interesting information about the Northwest. Next to that on the left we have a chat field. This is a field that you can use to talk about technical issues or to ask technically oriented questions. To the left of that field is a Q&A pod. In that pod you can ask your questions of Christie, and Christie will be kind of monitoring that as we go through the presentation today. If it's appropriate to answer at that point, she'll answer at that when the question is posted. Otherwise, she'll wait until the end of the presentation and answer the questions that haven't been dealt with. And with that, I'm just about done talking here. But let me introduce our speaker, Christie Artuso. Christie, first of all, has one of the most important degrees in the world, and that is the doctorate in education. And I can say that because I also have the same degree. Christie's a registered nurse, and she's the director of neuroscience services at Providence, Alaska Medical Center. Christie leads a specialized team of nurses, technicians, and support staff in collaboration with physicians who provide outstanding neuroscience services and quality care to patients. The Neuroscience Division includes a nationally accredited stroke program, a nationally certified concussion program, nationally accredited sleep disorder center, a neurodiagnostic testing for both inpatient and outpatient services for patients with neurological and neurosurgical disorders. She has more than 32 years of educational and leadership experience in the university-affiliated hospitals with recognized clinical expertise in emergency services and critical care. And on top of that, as if she's not busy enough, Christie is one of our newest board members on the Northwest Regional Telehealth Resource Center Advisory Board. And we want to thank her for joining us today. And Christie, take it away.
Well, thank you so much for the warm welcome, Bob, and it is a pleasure to be here today. I'd like to say I'm greeting you all from the beautiful state of Alaska, but this morning I traveled to the beautiful state of Washington, so I'm greeting you remotely, which may have contributed to a little bit of our technical difficulties, but I've decided to sit still and not touch anything, and maybe we'll make it through the next hour. So we want to spend an hour, give or take, talking a little bit about the Telestroke program in Alaska. I'd like to share some of our experiences and really share some of the challenges that we faced several years ago when we first developed the program, as well as some of the successes that we've experienced, and again, how we plan to move forward and why this is so important for rural health care throughout the United States. no presentation is good without a beautiful picture to start off the slideshow. Few financial disclosures. I do work for Providence, Alaska Medical Center. I am on the Speakers Bureau for Genentech, and I'm also a faculty member at the University of Phoenix, and I facilitate graduate and undergraduate coursework in their Healthcare Sciences Division, but I have no financial disclosures for this presentation today for the Northwest Regional Telehealth Resource Center. So I'd like to spend a little bit of time today talking about telemedicine, what it is as a technology, why we can use it to deliver some evidence-based care for patients with an acute focal neurologic deficit. I'd also like to discuss some of the outcomes that have been found to be associated with the delivery of care via telemedicine in rural settings, and then some challenges that we faced when instituting telemedicine for both the hub side, which is where your central support area is, and the spoke recipient of services. So let's have a little bit of fun, though, and look at the history of technology. If you ask yourself, how many years did it take to reach a market audience of 50 million? Well, radio took about 38 years. Television came along and only took 13 years to reach 50 million. The Internet took 4 years to reach 50 million, the iPod 3, and Facebook 2. I don't have the stats on Twitter and some of the other wonderful social media networking sites out there, but the reality is, what are we seeing? We're seeing a rapid increase in the use of technology. And what does that mean to the healthcare industry in general? So I'm going to ask you to keep that in the back of your mind as we move forward, because as a healthcare provider who has been in this industry for a little over 30 years, I can tell you I don't believe we're nimble enough to embrace what we are seeing in the world of technology today. And so we have to ask ourselves, what does that mean to our practice? What does that mean to the communities that we serve? What does it mean to the cost of healthcare? And how can we take all of those concepts and really think about what we need to do moving forward? So a couple of interesting statistics. The number of Internet devices in 1984 was about 1,000. The number of Internet devices in 1994 was about 1 million. The number in 2008 was about 1 billion. And in 2012, only 4 years later, 8.7 billion Internet devices worldwide. That's fairly impressive. Nationally, the top 10 in-demand jobs in 2010 didn't exist in 2004. So what does that mean to us? It means that we are currently preparing our children, young adults who are going to college for jobs that don't yet exist, using technology that hasn't been invented in order to solve problems that we don't know about. It really does reframe how we begin to think about healthcare delivery in the near future. Technology itself will continue to advance, we know that, and it will be an integral part of facilitating the quality in the delivery of healthcare in a very dynamic, ever-changing, extremely complex environment. So when we talk about telemedicine, it's important to make sure that we all understand that it's not just the bells and whistles that are so easy to embrace with the video conferencing. It really has a large number of devices attached to it, and it can go from very simple to very complex. In fact, the original telemedicine programs essentially involved either a two-way radio or a telephone. And so that was considered telemedicine because you were using a technology device to communicate between a provider and a patient or another provider providing care. There are several modes. Some are called store and forward, and that's where images or information is recorded, it's stored, and then it's sent to a provider for evaluation. An example of that would be radiology reads that many of us use almost every day, where we store the radiology images and then we send them to a radiologist who looks at them, makes a decision, a determination, writes his report, and sends it back to us. So that's essentially illustrating what store and forward really is. Remote monitoring would be a situation where you have technology that is actually connected to a remote site and is just looking at data. And so there are many programs that we use that actually simply look at the data from a remote perspective. And then we have real-time interactive video, and that's what we're going to focus a little bit more on today. So this would be live video, very similar to a Skype session, where we're using a HIPAA-compliant and secure portal to interact directly with a patient and/or another provider. The concept begins to represent clinical transformation. The way that we've always done things is no longer going to be the way we're going to do them in the future. And I want you to remember this concept because it is one of the most difficult to encourage everyone to embrace. That it's not about taking how we do things and fitting it into technology. It's about considering what technology can do to support the care that we deliver, but also asking the question, how do we have to change what we do to work together to achieve the best patient outcomes? And that can be a loaded question depending on who's in the room. And I will be talking a little bit about that very shortly. There are mobile technologies as well as electronic health records that have continued to mature as time has gone on. If we go back to think about the number of internet devices or how rapidly information is now shared through Facebook, Twitter, LinkedIn, and all of these social networking sites, electronic health records have matured almost as rapidly over the past 3 to 5 years. In fact, as we rebuild our electronic health records to accommodate or to align with current regulatory standards, we're almost behind the 8 ball because something else has been developed that would have worked better, but it took us 12 months to rebuild that record and then another 10 months to launch it in a large healthcare system. So somewhere along the line, we've got to consider how that impacts what we do. We have clinical decision support systems with continuous telehealth and telehealth monitoring that allow us to query information on patients and make decisions based on those patient situations or the treatment modalities that we want to share with them. There are national shortages of specific medical specialists, and one way to connect those medical specialists with patients in underserved communities is going to be to utilize telemedicine effectively. And then we have an increasing complexity of care as our population ages. So a very important concept to work into the mix and ask ourselves, how are we going to best use technology to meet these changes in the industry, the dynamic regulatory standards, the changes in the patient needs, as well as communities. So why did we pick stroke or telestroke? Because it's popular? Well, that's one reason that you could say. But in reality, in 2005, the American Stroke Association, so we're talking 9 years ago, developed stroke systems of care, emphasizing linkages rather than silos. In other words, historically, you had some great centers in the United States who were doing a wonderful job. From the time that Activase was FDA approved in 1996, they were delivering evidence-based care to stroke patients who could arrive at their facilities in certain geographic locations, in particular in metropolitan areas. But what the American Stroke Association said was, that's not what we need. What we need are systems of care that link those outstanding providers with the communities and patients that need them. And they also emphasized that we needed to develop a coordinated approach. That doesn't mean one side drives the care. It means you work together to deliver this appropriate care. And one of the goals was to improve access for patients in these communities to highly skilled care and services. Believe it or not, one research study actually documented the fact that there's up to a 30% incidence of misdiagnosis in some settings where practitioners or providers are less familiar with the clinical picture associated with stroke, especially complex strokes that often don't present as a classic stroke. And so we'll talk a little bit about some of that when I share some of our experiences in Alaska. But one of the concerns is that in settings where they don't see very many strokes, there's a high incidence of misdiagnosis or missed diagnoses where the patient is never eligible for care or treatment simply because they weren't diagnosed appropriately. Another goal was to make sure that through this coordinated approach that emphasized linking the care systems together, that we would be able to implement the latest evidence-based guidelines consistently. You have to ask yourselves, how easy is it to implement a new evidence-based guideline the day after it's published? On the average, the literature says it takes about 17 years. And I'm sorry, as I age, I think that's a little too late. I think we need to be much more nimble in our healthcare environment. And so the idea behind this concept of a system of care was that we could drive evidence-based guidelines to the forefront, to the patient, to the communities, on a much more robust and nimble basis, because we would be working together to do that. And then finally, most importantly, that we would be able to intervene at an early time for patients with a diagnosis of stroke or suspected stroke. So why Alaska? For those of you that don't know me, I'm originally from the Northeast. I was born and raised in Pennsylvania, but I spent 26 years of my professional career in the New York City, New Jersey metropolitan area. And there I am in Alaska. As of 7.5 years ago, they enticed me to engage in a great adventure. And when you look at Alaska, we realize that we are 586,000 square miles. We face distances, very expensive transports. Many of our cities are not connected by roads. In fact, 75% of Alaskan communities are not connected by roads to any hospital. 25% of all Alaskans live in communities of less than 1,000. We are the largest state in the United States, and in fact, our favorite saying is that if you divide Texas in two, they'll be the second and third largest state. We'll still be number one. But the reality is that we only have 722,000 and change people in the state. And that makes us 48th in the United States in population. So we are a very large place with very few people, but they're spread out. We have a total of 31 healthcare facilities. The 3 tertiary care facilities are in the city of Anchorage. 40% of the entire population lives in Anchorage. That leaves 60% that are outside of Anchorage, with 75% of those individuals not connected by roads to a hospital. So you have to put that into perspective, why Alaska is so well suited to telemedicine and telehealth. We do have 11 community hospitals who provide excellent care to their communities and are great partners in this project. We have 13 critical access hospitals. Many of them are connected to us for telemedicine and a few other telemedicine services for Telestroke. And then we have 7 specialty or military hospitals, including mental health facilities, rehab facilities, etc. So we do have healthcare facilities, but again, the distances really do present challenges. Weather, geographic barriers. We fly fixed-wing aircraft, we fly helicopters, and believe it or not, when my medical director, who is a vascular neurologist, moved to Alaska, the very first consult he had actually started on a dog sled. He came in the next day and said, I wasn't sure where I was. So just to give you a little perspective, and I love this graphic because it really shows you that from Barrow to Juneau is essentially the distance from New York to Orlando. And you can see on the map where Anchorage is and Fairbanks, and it's fairly true, although Fairbanks would actually be a little bit further south if it was completely true to scale. But it shows you how large the state itself is. The eastern coast of Alaska is essentially the distance from the tip of Maine down to the end of the Florida Keys. And most of it you can't drive. There are no roads there. And so when you think about people that live in the peripheries of Alaska as well as those that are in the Anchorage Bowl, even in the Anchorage Bowl, distance is a significant barrier to the provision of care. So I think this picture gives a little bit of perspective about the challenges that we face. And yet, I ask this question a lot, and I'll ask all of you to think about it. Does any patient or any person who is a citizen of this country deserve a lower level of care simply based on where they live? And I think we could ask ourselves that question anywhere in the United States that we serve rural communities, because all of our communities deserve a high level of care regardless of their location. The role for the healthcare provider and the healthcare institutions is how do you provide that care to these small rural communities within a cost-effective program? And that's a difficult question to answer sometimes. There are geographic penalties that are associated with stroke. We actually have research that has illustrated that the quality of stroke care is dependent upon the hospital that you go to. Several states in the United States actually have legislation that says that EMS, your emergency medical services, must take patients to a recognized stroke center if they have the signs and symptoms of stroke. In Alaska, that wouldn't be very wise simply because all of our stroke centers are in Anchorage, so they're going to head there eventually, but we want them to go to the nearest facility, ideally connected with telemedicine. But in other states where there are choices, it illustrates that this research has provided us with reliable information that shows us that we have to make sure that these patients get to the right place so that they do get better care. If you live in a rural area or an area that is underserved for acute stroke care, you will never receive the only FDA-approved pharmaceutical agent for treating stroke. They just don't give it, and it's not faulting those providers in those areas. They're not comfortable giving that medication. They're not comfortable diagnosing and making sure that the patient really fits into the criteria for receiving that medication, and yet there's a 30 to 35% chance that the patient will improve in their symptoms. And there are some professional debates that continue to exist, but that medication has been approved since 1996, and the majority of us who deliver care to patients with an acute focal neurologic deficit feel very strongly that we should pursue immediate treatment. And then we have other treatments, including catheter-based treatments in a cath lab, and that we can go in and remove a clot. So we do have other avenues to go into at longer hours. So there's a geographic penalty associated with stroke outcomes. If you live in a rural area and you're not eligible or you can't access evidence-based care, you likely will have a much more severe or lifelong disability if you have a stroke. If you're near to an evidence-based stroke center, you have a better chance of recovering from your stroke and disability. And this is all supported in the literature. So it's not a point that is really arguable at this point, but what it is it's a platform for us to build on and look at the efficacy of utilizing the tools we have to improve the delivery of care. So why stroke in Alaska? Why was that the first program in the private sector that we looked at? Well, our death rate for stroke, our mortality rates, are 6% higher than the national averages. Even though the national death rate has been decreasing slowly over the past few years, potentially linked with that increase in the number of primary stroke centers, an increase in the number of telemedicine programs, and an increase in the number of organizations that have improved their delivery of evidence-based care for stroke patients, the Alaska death rate has stayed the same. And that's simply because of access to care. We do have a higher smoking population than the rest of the lower 48, and we have a higher number of people who are overweight or obese, and a higher elevated cholesterol rate. So all of these risk factors are significant in the state of Alaska and serve to increase our population's risk for stroke as well as their risk for poor outcomes. The barriers associated with telemedicine in general, well, number one is defining the specialty. In 2007, my medical director and I went to the Board of Medicine in the state of Alaska to really pitch this idea that we felt that it was important to deliver care through telemedicine in Alaska. And although their state statutes had a little bit of a gray area when it came to that physician-patient relationship, they felt strongly that telemedicine was not necessarily a good idea for a lot of different applications, but they did agree with us that for stroke care it was appropriate. But we have licensure and liability issues throughout the country. It's not clear who's more liable, the ER physician or the provider at the site, or the telemedicine specialist who's linked in through a telemedicine portal and provided recommendations for the care of that patient. What's interesting is, to date, there have only been lawsuits that have moved forward for failure to treat stroke patients. To the best of my knowledge, I haven't been able to find any case law that has supported any litigation that's moved forward involving a telemedicine stroke doc who has treated a stroke patient, even with negative outcomes. So I'm sure there will be eventually, but the reality is that the care that's being delivered is evidence-based and with proper documentation. It seems to be sustaining the test of liability at this point in time. We also have licensure issues. You have to be licensed in the state that you're practicing, and some states do not have a telemedicine component, so they require you to have a permanent residence. So these are the types of things that all of us had to look at and to determine how much of a barrier this would be and what would be the cost associated with credentialing physicians outside of the state and obtaining privileges within the state. We also have to look at policies. If you think of our past, we've never really developed policies that address the use of telemedicine or connectivity between hospitals that aren't related, involving privacy and security. And so our policies need to reflect our awareness of HIPAA and high-tech regulations and how important it is to safeguard that patient information and make sure that our systems are secure. On the other hand, is it overkill? Have we looked at these things so reliably that we've almost not seen the forest through the trees, and we are now focused so much on closing down our portals to protect information that it actually interferes with our ability to deliver care? I don't necessarily know the answer, but I think it's something that we have to discuss. And how do we break down some of those barriers so that we can meet the needs of communities across the United States? Simplifying the process. We can't make this too complex. It needs to be point and click. Unlike our little technology issues earlier today, we need to be able to move forward very simply. The folks that partner with us in our community sites need to be able to turn a machine on and it has to work. There should be nothing more to it than that. And so we have to work together to make the process on both sides simple, because if it's not, it won't be used effectively. And then it has to be sustainable. What I find interesting is there's really no reimbursement directly for telemedicine. Now, physicians can be reimbursed for their consult, but at a much lower rate. And certainly there is legislation and there are lobbyists who are working on addressing these issues. But the reality is today, there's not really a great financial model that is necessarily sustainable. A lot of times we talk about the fact that our telemedicine programs save a tremendous amount in healthcare costs simply because we decrease unnecessary transports, we improve outcomes, we decrease disability, and we've seen all of this. But if you ask yourself who's benefiting financially, it's the payers, and yet they're not participating at all in the infrastructure development. So these are conversations that are yet to be had, or I should say are underway right now. What are the advantages of a Telestroke program? Well, number one, access to appropriate care. We have one vascular neurologist in the state of Alaska, and we have about 8, maybe 9 neurologists in the entire state. And so that's not very many neurologists for 750,000 people. And the reality is they don't even all have access to even one neurologist. So utilizing telemedicine, we can provide communities and patients with access to a neurologist without air transportation. It also fosters improved care decisions in that putting the right eyes on a patient will actually improve the decision that is made. Having a physician who has seen and evaluated 10,000 or 15,000 stroke patients is going to be a very different model of care delivery than a physician who sees 3 a year. And you're not faulting that physician. The physician who sees 3 a year simply can't develop that level of expertise. But one of the advantages to using technology is the fact that it's going to bring those qualified providers together and allow them to share that expertise with communities. It gives communities access to specialists even through a consultation model or teletrauma or telepsychiatry, so we can look at different specialists. And it does help us improve quality because we're going to improve the delivery of evidence-based guidelines. We're going to help our community partners meet their quality guidelines as well. We can do monitoring of patients, and then we can do e-consults with recommendations. So what you're doing is you're broadening your medical staff base without actually increasing your costs significantly. And I think one of my favorite aspects of telemedicine and Telestroke has been the education and training that it has accomplished. What we found in our partner communities is after we do several consults and then we do another year's worth of consults, that site is equally as qualified to make these care decisions. And they have learned a tremendous amount about the identification of these patients appropriately and what care is needed. In fact, I would be willing to say that our community partners are probably better at delivering stroke care than we are at the hub, simply because they focus on that stroke care when the patient comes in, and they're a smaller group of individuals who work together very well. And so what we've seen is a tremendous increase in the quality of care at the what we call the spoke site, where our community partners are located, simply because they have an additional coach in the background who has provided some guidelines one-on-one in real time and helped them meet those guidelines. So they get the expert consultation. They can also access conferences. We've been toying with connecting for some video conference education events as well. But the real-time education with those patients is what has been extremely useful for them. So in the end of 2007, believe it or not, there were over 12 Telestroke programs in Europe with 18 hub hospitals and 77 spoke hospitals. They had evaluated over 20,000 patients, and this is just a few years ago, with 2,200 Telestroke consults each year, excuse me, and achieved a benchmark of about 18% of those patients, total number, receiving systemic thrombolysis. So that's access to evidence-based care 18% of the time in all the patients. So usually 100% of eligible, but 18% of all patients were receiving thrombolysis. So that's incredibly impressive, because in the United States the average is about 6% right now. 5 years ago it was 2%. And so we've made gains with our own telemedicine program. So what we can see is that that's a valid assumption, that as you implement telestroke and telemedicine and develop those relationships and improve the expertise, you will increase the number of patients that receive evidence-based care. But it takes time. Interestingly, in 2006, the World Health Organization actually declared that in Europe, one of their prime strategies was to make sure that all patients in all communities had access to a continuum of care, had access to acute stroke units that we know improve patient outcomes, had access to rehabilitation, and access to secondary prevention, so appropriate treatment to prevent any recurring incidences. This is in Europe, but we don't necessarily have the same thing in the United States yet, which is unfortunate. The disadvantages to a telestroke or telemedicine program, well, it's expensive. There is a lack of resources. Early on, many of the early adopters utilized grant funding to actually support the onset of a telemedicine program, but grant funding is short-lived. And so what I think we have to realize is we have to develop sustainable programs that are not just continually costing us money. There's a rapid change in technology, as all of us know. Just look at the iPad Air, the iPad Mini. I mean, things are changing faster than we can buy them. You no longer have 2 years from the time you buy your smartphone. The next rendition is out in 6 months. And so as technology changes and the regulatory statutes change, the needs for the type of technology that's going to act appropriately over our technology access points is going to change. How do you justify the resources that are needed to replace it? So these have to be thought of, and I mentioned licensing and credentialing before. Another really important point is reliability. We have to think about the infrastructure and technology in rural communities and the available bandwidth. In Alaska, interestingly enough, there are many areas where you have no cell phone access, and there are a significant number of areas. When the Joint Commission came up the first time, they were appalled that we didn't teach our patients to call 911, at least not all of them. And I looked at her and said, well, we don't have 911 in all these communities. And she said, that's ridiculous. Everyone has 911. Well, we don't. And so although we have it more today than we did 7 or 8 years ago, the reality is there are bandwidth issues in rural communities throughout the country. Alaska is a bigger exception. We have a lot less bandwidth and still building our infrastructure. And there's trust and distrust in your communities. What's interesting is that oftentimes you go into a community and the physicians, the providers look at you and they say, well, you know, we do a great job in our communities. And that's a very true statement. But the reality is, despite the fact that they do a great job, they still need that additional specialist support. And so working together to build a bridge between that trust and distrust is really important. And then there's a perception of concept, responsibility versus accountability. What are the legal limitations that we actually have to face? So as we developed our program in Alaska, we asked ourselves 5 what I called research questions, or how we framed our project. We asked ourselves, what did we have to be a statewide stroke center of excellence? What things did we need that we didn't have? And then what were the essential elements of a telemedicine stroke program? Which hospitals in the state of Alaska actually could be partners with us? And that was a big question to ask, because not all hospitals actually had the ability to work with us because of their own infrastructure. And then what hardware and software requirements were necessary? And that became a very important question for us, and still remains an important question. And then what financial support would be required? So to answer those questions, I'll give you a few insights that we learned along our journey. The essential components that we needed to make sure we had was, number 1, we had to have a full range of services for all needs of the population in a community. We had to have support for evidence-based care. In other words, you can't just say you can give it. You have to be able to support that. And we needed to have clinical consultation for the evaluation, triage, and even transfer of patients when necessary. We also needed to make sure that on both sides we had the required available diagnostic tests. And then most importantly, we needed to educate the public. And so I collected data when we first began this program and looked at the time lapse between the onset of symptoms, so when a patient first had their early symptoms, until they actually accessed care in the emergency room. And in the Anchorage Bowl, so we're considering in an area where they could commute or enter into our hospital, the average time was 17.6 hours. Well, when you can only treat this patient within the first 3 to 4.5 hours, you've already lost the battle. And so we recognized that right away we needed to begin to educate the public significantly. Today, that average time is about 6.3 hours. So we have made a tremendous gain in the amount of time between the time a patient recognizes that something is drastically wrong and the time that they actually come to the emergency room. What are the components of a telemedicine stroke program? Well, we needed resources to support the infrastructure. That was number 1. So we had to have some serious conversations about how we were going to fund this. We also needed two-way audio video. I'm actually chuckling here, with reliable connectivity. That's what we needed today, and so far so good. But the reality is that's an important concept, because as I stated before, you have to make sure that it works on both sides, because as soon as you can't connect your physician, the physician is going to say, I don't need to do this. As soon as your spoke site, your community partner, can't connect to a physician, they're going to say, what are we wasting our time for? And so you need that reliability, and that's important from both the vendor perspective as well as your infrastructure with your connectivity, your fiber lines, your hardwire, your wireless connection, etc. You have to have 24-hour qualified physician support, and this is really important because we want to make sure that our physicians are not only qualified but experts and are very comfortable using this type of technology. And most importantly, for stroke care, you need to have a CAT scan at the spoke, and that's based on what we call a hub and spoke model that I'll show you in a moment. But you've got to have a CAT scan where the patient presents, because that's going to give you your baseline for making an evidence-based decision. And then we have to have some appropriate providers and telepresenters at the spoke site who are going to help present this patient, that are going to be there to act on behalf of the patient, to administer any treatments that are recommended, or to make sure that those studies and tests are done. A hub and spoke model looks something like this, where you have essentially three-way connectivity. You're going to have your comprehensive stroke center, where you have your major source of evidence-based care and higher-level treatment options. But then you have your rural hospitals, and not always just critical access. Some of these are community hospitals that may just not have access to stroke specialists. And so it's a great model where they can access stroke specialists, but at the same time, the patients may be able to stay in that hospital if they don't require a higher level of care. So it allows more selectivity and appropriate-based care for each patient. And then your physician may be in a third site. They could be at home. They might be in what we call a bunker, or an audio conference room where they're connected to the internet, either through a hardwired connection or a laptop, or even a specially based control center where you actually build your control center in your hub site. So we asked ourselves which hospitals in the state of Alaska could actually had the ability to transmit and receive these internet signals. Well, we had to analyze all the hospitals, and we looked at location, how far away they were, what type of internet access they had, and believe it or not, originally, when we started this project, many of them had DSL or dial-up. And so that made a difference in selecting the hospitals that we could initially partner with because, again, you want to make sure that your connectivity is going to be reliable. And then we had DICOM-compatible CAT scanners, how many inpatient beds did they have, how many emergency department visits per year. So we wanted to make an estimated guess on how many stroke patients we would be seeing so we would have the right number of providers. So our early adopters were Bartlett Regional Hospital in Juneau, Providence Kodiak Island Medical Center, Seward Medical and Care Center, Central Peninsula General Hospital in Soldotna, Providence Valdez Medical Center in Valdez, and Providence, Alaska, which is our hub. But we also, actually it's not a CA with 4 beds, that's Valdez. Error on the slide there. That's our hub in Anchorage with 360 beds. And we also have a telemedicine portal there so that our neurologists can connect with our telemedicine patients in the event that there's any delay in them getting into the hospital. So they have a choice in connectivity. This is just a map that shows you with the red stars where we are currently located. Just note that between Anchorage and Juneau, that represents about 800 miles, so it's a pretty good distance. And then the yellow stars are areas that we've been asked to evaluate for the presence of telestroke. We're also looking up at Nome, which is up near the Norton Sound area. They would like very much to have a telestroke cart, and we're, believe it or not, waiting for a fiber cable that's been laid in that Norton Sound area to go live. So we're working with GCI on that, which is one of our providers. So again, you can see how complex it is to look at all the players in these areas and make sure that you have good communication. So what kind of hardware and software requirements were necessary? Well, we mentioned that we looked at the type of internet connectivity, but we also looked at high-definition cameras with accessible software that we could control from our site, a laptop versus a mobile computer station. We have both set up at our hub site, but in the spoke sites, in our community sites, we use basically a mobile computer station. Tech support, who's going to support this, and who's going to support it at a non-Providence hospital or one that is outside of our network? So these are questions that we had to answer. And then electronic medical records, and then of course DICOM imaging sharing, especially in hospitals that are, again, outside of your own network. So all of these questions have to be answered for as you develop your program, and they're all as important. We also looked at fiber optic lines connecting communities, wireless, DSL I mentioned before, and portable versus wired, and tech support, travel and education. How are we going to fund all of this? And then there's the receptiveness. We had some challenges early on with communities that said, we don't think we need this. And so we worked for quite a period of time to make sure that we all, both had common goals set up and that both sides recognized this was a partnership and not a one side versus the other. So we had several options to look at this time. We had an EICU option, which was in process. We were using it in our own local hospital, but it didn't connect to any of our other outside hospitals at that time. Now it does. We looked at wireless carts. Reach Health was one that we looked at and we used initially, and then we transitioned over to the InTouch system. There's Polycom Global Med, which is hardware only, and then you basically build your own infrastructure, or do you make your own? So these are important questions that you want to ask as you're developing this telemedicine network. What financial support will be required? Well, you have to think of the cost of the technology and connectivity. Of course, today it costs less than it did 6 years ago when we started the program. Basically, it costs close to $1 million for 3 years, so about $350,000. I think the first year was a little over $400,000 to get it off the ground. Important piece of information to think about for your financial pro forma, because you want to consider where you're going to get these resources and how you're going to justify it as you move through. We also want to think about the costs associated with maintenance and replacement for the hardware, as well as education and training. You don't just set it up and walk away. You've got to maintain the relationships, the education, and make sure that the people at your sites are very comfortable with the process and how they're going to move forward. Financially, you want to look at a revenue model and talk about how you're going to manage the revenue and what does it look like. in this kind of system, it's not about patient referrals per se, but it's about appropriate care and better outcomes, and that translates into a positive revenue stream. It's a cost-saving model because you're going to avoid unnecessary transports, but you're going to transport the patients that truly need the higher level of care. So it benefits both the spoke community and the hub. And then you want to think about strategy as we look at community health and community care and supporting those needs in these communities and improving access to services and care. How does that fit into your long-term strategic plan? So these are all important questions. Look at the technologies that we have today. We have electronic stethoscopes that actually reach through telemedicine. We have audio video. We can do some types of interventional work. We can actually control robots. We can help with surgeries. We can even do ultrasounds and see the images live on the other end. So we have tremendous technologies that we can work with together to provide a better patient picture in order to deliver evidence-based care. So how has technology impacted the entire system? Well, we've now moved on to electronic medical records. We have computer chip-based clinical monitoring devices. As I mentioned before, we have remote wired and wireless communication used in telemedicine and EICU. And then we have decision support software, which I'll mention for just a moment, that utilizes software that collects data from patients and actually helps us make clinical decisions based on that data that's imported. But the implications are that we have to change what we're doing and how we're delivering care, and I think that's very, very important to recognize. We want to think about it's going to change what we expect from the healthcare system, and it's going to change the community's perception of healthcare in general. It's also going to change the provider, nurse, and patient relationship from its traditional model to something that's a little different. And so we need to not only embrace these changes, but help facilitate them in order to meet the needs and the goals of providing that evidence-based care. So developing your program, you're going to look at your vision and align it with your organization's vision and mission, but more importantly, you want to assess your community and align this vision with the community's vision. So there's a significant period of time that is spent gathering data. You want to also look at the program objectives and look at your infrastructure and identify your needs, and then develop how you're going to measure success. Early on, we were measuring success initially by the number of consults that we did. And we realized very quickly that that wasn't going to be a reliable measure of our success. What we needed to measure was the number of patients we were actually able to facilitate treatment of. So our original statistics when we treated patients with thrombolytics in Alaska was essentially 0. In 2005 and 2006, basically 0 patients were treated with thrombolytics in the state of Alaska. And we knew we had a little over 2,000 strokes a year, give or take, in the entire state. Providence, Alaska, the hub, actually saw about 300 stroke patients every year. 0 were treated with thrombolytics, despite the fact that we were the tertiary care center. And the same was true in the other tertiary care centers. By 2007, when we first began the concept, I believe we treated 2. 2008, we treated about 6 patients. In 2009, we treated 10 patients. And in 2010, we now treated 15 patients. Last year, we treated 32 patients. And to date this year, we've treated a little over 30. So we're looking at a consistent growth pattern, and we're still focused on improving the door from symptom to door time so that we have more patients who are eligible for treatment. What's really been satisfying is that we're treating about 100% of all eligible patients, with the exception of those that come in with very, very obscure signs and symptoms that are very difficult to recognize. So as we're treating these patients, we're recognizing that we are getting evidence-based care to the communities. One clinical example I'd like to share with all of you involves 3 patients in one of our communities. Interestingly, over the course of a year and a half, these 3 patients had identical strokes. The first patient actually had a first branch MCA stroke in their particular community hospital, and they did not activate telemedicine even though it was available at the time, but eventually did call for consultation, and then the patient was flown to Anchorage. Patient had permanent disability, could have been eligible for treatment, did not recover well and had permanent deficits with paralysis and loss of speech. The second patient was seen about 9 months later, identical site of the stroke, identical symptoms. This time they activated the telemedicine, but we were uncertain because of a few pieces of information whether the patient was truly eligible for thrombolytics. So this patient did not get treated with thrombolytics and then came up to Anchorage a little bit later, but there was a significant delay in the transfer. And so the patient may have been eligible for a different level of care with clot retrieval or a catheter-based intervention, and potentially could have done better, but also ended up with significant disability and deficits. The third patient came into the same community hospital about 4 months later, came in with the identical stroke, the identical vascular presentation, and also the identical symptoms. They activated the telemedicine cart. The patient was immediately evaluated by a vascular neurologist and treated with thrombolytics. And that patient was then transported up to the tertiary care center in Anchorage. On admission, the patient's symptoms were beginning to resolve. Within 24 hours, the patient's symptoms had almost completely resolved, and 3 days later, the patient left Anchorage with no deficits except a slight right hand weakness. And so the identical presentation, identical time frame, the only change in the 3 patients was the activation of telemedicine and the immediate intervention that was appropriate by a telestroke or a stroke specialist. And so we were able to show that particular hospital and the physicians very clearly, even looking at images, that in these cases, with identical presentations, we could show a much more positive outcome. Now, you could say that was just one case, but that isn't the only case that we've seen this in. It was a beautiful thing because we had 3 patients that had the identical site of a stroke, and so we could really compare apples to apples. But we could say that in all of the patients that we've treated, we've seen very positive outcomes with very low level of complications. And what we'd like to see are more patients reaching the hospital within a reasonable time frame where they are eligible for those treatments. So it is very important that you look at what it means to be successful, and you also look at how you're going to measure those outcomes in your program. And that can be a living target. It can change. So as you establish this vision, you want to ask yourself critical questions. Where do you want to go, and how does that journey affect your objectives? Are you willing to have a living document that's going to change? Make sure that your vision is aligned for the telemedicine program is aligned with your organization's vision, because if they're not, the program will not survive. And is your program objective the same as the organization's objective for the program? In other words, make sure that you've had those good conversations with your superior officers in the organization and that everyone's on the same page as you're building the program, or you'll have challenges with your success. So we developed our vision, and I think this illustrates a little bit about how you build a program that aligns with the organization's vision. Providence Health and Service Alaska vision is, as people of Providence, we reveal God's love for all, especially the poor and vulnerable, through our compassionate service. That's their mission statement. The Neuroscience Service Line has a vision of to be recognized as Alaska's premier neuroscience center of excellence, providing collaborative services designed to meet the needs of the state. So you see, it builds nicely on the organization's mission. And then the Telestroke program's vision is to provide collaborative evidence-based stroke care that meets the needs of Alaska. So again, we tried to build closely on the organization's mission and vision. As we built the program, we developed our 7 potential spoke sites in Alaska, and we began to build those relationships that I spoke about before. We implemented telemedicine at 7 sites and maintained the robust support with those sites throughout the course of the next year and a half and then ongoing. We have also identified subsequent sites for implementation and developed plans for more utilization and implementation as we continue. I mentioned the community before, and I just want to briefly mention again, you really do need to assess your community and consider what needs the program would meet. It has to meet needs in the community, or it won't be well received by either the healthcare providers in that community or the members of the community. So you want to look at your services, who would use the service, what technology is available or is needed, and then the connectivity again. So really important that you keep that focus at the forefront while you're developing a program. And then the impact on the providers in nursing, as I said before, things are going to change. How is it going to impact your workflow, your delivery of patient care, education expectations, and who is the champion? Is it you, or is it someone else? We need to ask the right questions. What is the impact on patient outcomes? What were the objectives, and did the program develop the infrastructure it needed to achieve those objectives? Did you provide the right education? Because those telepresenters at the community spoke site need to be comfortable presenting a patient through telemedicine. And what outcomes did you expect? For us, it was really the outcome of getting patients to the hospital quicker so we could participate. So we worked a lot with different organizations in community education. And how are you going to measure those outcomes? Are you going to collaborate, share data, share information? So you want to make sure that you're compiling your data and using your data to drive change and move forward. We really talked about defining the objectives of the program and aligning program objectives with the organization's objectives, the results and the outcomes that you want to accomplish, and then make sure that you have opportunities to use the equipment frequently to maximize competency. So in case you don't know what you're looking at, for those of you that want to guess, those are bear paw prints down a little trail very near to where I live, and that little bear was following us as we were on a hike one day. So as we talk about challenges, what do you face when you do something like this? Well, relationships is one of the largest challenges. You want to make sure that you build those relationships in a very positive way and that you have aligned vision, objectives, community perspectives, and you want to work closely together. The infrastructure certainly can be challenging. Who's going to manage it, especially if it's a community hospital that's not part of your own network? And even on your own network, is your own IT support going to manage a vendor's hardware and software? How's your relationship between the vendor and your own organization? Education, making sure everyone understands the changes in evidence-based care with stroke patients or with whatever service you're providing. And then troubleshooting. What do you do when things don't work? I've always said one of my favorite stories was when I was fishing in the Kenai Peninsula one weekend, and I got a call from Central Peninsula Hospital from the ER physician who said, "You gave me your cell phone and said I could call you." And I said, "I did say that." And he said, "Well, the cart won't work." And I said, "Well, I have fishing waders on, and I have no makeup on, and I have a baseball cap on my head, but I'm willing to stop by," because I was fishing very close to the hospital. And so I did stop into the hospital and fix their problem, which was not a serious problem, but they needed somebody to really troubleshoot it right at that time. And it was just lucky that I happened to be in the area. And we would have found another way around it, but it worked to build a tremendous number of relationships because I didn't mind that I had fishing waders, and they didn't mind at all. They said everyone does it in this neighborhood. But the reality is it was important to make sure that you did something to establish that relationship. In the spoke or your community site, the trust-distrust issue always comes up. You want to make sure you're aligned and that you provide them with support, but not too much support. They have to have a say in everything that's happening. Education, and then make sure that they can use the device frequently. In one of our sites at one point, I had gone to do an educational program and said, you haven't had much activity. And one of the staff members said, well, that's because it never works, so we just stopped using it. But I had no idea. So we had a conversation about it, and it turned out that one person had a bad experience, shared that with another person, and they decided not to keep using the telemedicine cart. And so the reality is it trickled down. So you want to make sure that you maintain that relationship, have practice sessions, and make sure they're using it frequently enough, if they don't have real case examples, that they are comfortable with it. And we talked about those IT resources. So what are our outcomes? Well, we've had success in our implementation in 6 different locations. So we have good, reliable connectivity. For the most part now, we had some issues about year 3, and we believe we've resolved those. We see continued increase in referrals from those sites, meaning outside of the neuroscience area, we see a better relationship building with those communities, and that's important to us. We also see a decrease in unnecessary transportation, and that's a significant statistic to measure. How many patients were sent to you that really didn't need that higher level of care or that you couldn't treat? And so decreasing that transportation, how does that translate into healthcare dollars, and where do your payers come in to the mix? And then we've seen an improvement in TPA treatment in the state of Alaska. So that's our Activase drug, medication for stroke. We started at less than 0%, maybe 0.025%. and have gone up to about 4.7% right now. At a high, we were sitting close to 6% at one point, and then we had a decrease in the amount of, or an increase in the amount of time that lapsed between symptom to door, so less eligible patients. And that did change our percentage rate, but 4.7 is a little bit higher than the national average at that time, and it's continuing to stay at the national average. We're seeking 18 to 20%, so we're looking to be much higher than that, but we're seeing gradual improvement. And then an improved identification of stroke at our community sites. And so we see them identifying more stroke patients than they had in the past, and so that means an increase in expertise. We've also implemented an electronic ICU at several of our sites, and that's been very useful because we've been able to provide a higher level of care at the sites, and more stroke patients are able to stay at those sites even when we provide treatment there. So future strategies, we developed the Alaska Collaborative for Telehealth and Telemedicine, a group of stakeholders who have come together, developed a 501c3 organization that is really a nonpartisan, non-biased group of providers who are interested in building telemedicine and telehealth throughout the state of Alaska, working together and collaboratively. So that's been a great experience, and it's been about a year and a half since we started that organization. This is its first full year of activity. We had our first statewide conference in October, and it went very well and was pretty well attended, so that was encouraging. And then the Alaska region for Providence has developed many initiatives that are related to telehealth and telemedicine, so we're doing more outreach. And then the entire system has begun a program where we're looking at coordinating our telemedicine and telehealth throughout the 5-state region. So again, connecting resources and looking at distributing scarce resources to underserved communities. And then certainly looking at the evaluation of our systems, our reimbursement, our infrastructure, our resources, and our community needs, all very important strategies for our ability to move forward in the end. So in summary, I think it's important to note that telemedicine itself is going to be a rapidly growing strategy for the delivery of healthcare throughout this country and global communities. We're going to use technology to access specialized and acute care services, and then we're going to improve the overall health of communities because they'll have access to more specialized care. But more importantly, the way that we deliver health care will change. So I want to thank you for your time today. We tried to keep it pretty close to the prescribed amount of time. And I would be very happy to entertain any questions right now, or you can jot down my contact information and email me or call me, whichever works for you.
Well, Christie, thanks a lot. That was a fascinating presentation. I really love to see, especially that you mentioned using the equipment, training and testing, and making sure it works even if you don't have an emergency going on, because that's very critical to any aspect of telemedicine. If anyone has questions for Christie, please put them in the Q&A pod down in the middle of the bottom. Otherwise, you're welcome to contact me, and I can relay the questions to Christie or contact her directly at the email address as shown. A little bird told me that about half the people here today are from one hospital that's looking at implementing a Telestroke program. So I really encourage them to stay in contact with all of us because we can get answers to questions that they have. Again,
absolutely, and we're more than happy.
And if you'd like to get a copy of Christie's slides, of course, you're welcome to download them in the file pod, Telestroke Alaska. And you can get those downloaded, get the figures that Christie's brought up, and also have her contact information there. Martha will put the survey link up on your screen now. Please take the survey and please tell us what you'd like to see in the future, as well as tell us what you thought about Christie's presentation today. And Christie, it doesn't look like we have any questions. I'll thank you again and thank everyone who's still with us for attending. And everyone, stay in touch.
Thanks very much, Bob. Have a great day.
You too. Happy meeting.
Thank you. Bye.
Bye.